Thank you so much for having me, and I just want to start by saying how impressed I am with the presentations I just saw. You have great work going on here in Nebraska, and I'm absolutely in awe of all the things I saw, so hopefully I can add to that. I feel a little, we certainly do not have this in North Carolina where I currently practice, but hope to get there someday. So congratulations on all your hard work, and know that the hard work you're putting in, I mean, this is absolutely phenomenal. I get to talk to a lot of different health departments because of some of the work, and this is top notch, so congratulations. I was asked to come and talk about approaching a reluctant administration, so I have a little secret to share. What I don't often put in my bio, I focus it on stewardship, but there was a period of my career where I masqueraded as an administrator. I was at the University of Rochester. I was their Associate Director of Pharmacy over their clinical services for about 6 years, and as part of that work, I actually sat on the senior management team of the hospital. So I have been on the inside, and I'm back out, and I'm going to share the secrets with you that come as part of this. I do have some disclosures, and what I hope we can do is help generate some ideas. I know we have people from different practice settings here with us today. I primarily talk about hospital, but I do have some examples for long-term care, and then I want to have some time at the end for questions and discussions about what may or may not work locally. So, typically, I help people with a lot of different program pitches for stewardship. And I think we always start off at this high level. We need to do the greater good. There's a big problem with antibiotic resistance, and we need to save our antibiotics for the patients with the most resistant infections. And at this hospital, we start with the ask. We need this many pharmacists and this many physicians to support our stewardship program. And if you fund us, we're going to decrease some antibiotic costs. We're going to fight resistance. I would argue few people really know what that means tangibly, especially in an administrative suite. We're going to increase access to rapid diagnostics to improve patient care. I see that all the time. I'll tell you what administration hears. Oh, that sounds expensive. Rapid testing sounds expensive in our hospital. And we're going to result in better patient care. That's very nebulous. What is better patient care? I mean, that's part of the reason we all want to do stewardship. But in a proposal, it's not very specific and concrete, and we'll get fewer readmissions. We'll be able to comply better with accrediting agencies. I think this has gotten a lot more sound in the last decade than it used to be, but that used to be a little weak. And then in summary, funding a program will have a little bit of cost savings. We'll have very nebulous better patient outcomes through fewer resistant infections and antibiotic-related drug events. But we don't really tie in, or most of these proposals, quite frankly, I've written a bunch of them, they're somewhat soft. This example specifically was taken, Brad Spellberg has taken a great interest in this work as well. And so I was happy to see that he has put into publication a lot of things that we were seeing in practice. But there are lots of great reasons to do stewardship, but we have to realize the realities of working in healthcare today. So what are the problems with this sort of typical pitch? The first and foremost assumption, and I know it sounds silly when you say it, but everybody always feels like there's new money to be had. So I'm going to go in and I'm going to get new money. Give me the new money. There isn't new money. Hospital budgets are fixed. There is a set amount of money, and any dollar you get for stewardship is not going to someone else. This is not the same way that others are compensated. It's not the same way a lot of things work in the business world, and you have to realize that. Especially if any of you practice at an academic medical center, it is very important to understand that the way that the academic divisions, like the Department of Medicine, where the physicians are employed, and the hospital-based departments like pharmacy, lab, radiology, the way they do accounting is very different. And that's not often well understood. And so you really have to learn, as much as I was not intrigued by learning a lot of accounting, I had to learn a lot of accounting to do my job and justify my clinical pharmacy programs. And so realizing that your funding has to come from existing funds, from the existing budget somewhere, unless there's a large outside grant, but then you know there's always concerns about sustainability. So I'm going to hopefully show you some ways to be creative. So the reason people ask me to talk about this is I have become a ninja in saving money, and you better believe they don't get $1 of that back. I never put $1 of savings on the table without a different way to spend it, and that's the way you need to approach these things. If I can come in, you have to go in and justify cost offset, very important. And So if you can really well justify your proposal, not just because it's the good thing to do. You know, hospital administrators don't really get a proposal to be like, oh, we want to do this thing that's bad for patients. Every proposal they get is something that sounds really good for the patients. So you have to find a way to justify doing it in either a cost-neutral way or a way that helps meet another problem. And so really the key to really good proposals for administration is to find out where the problem points are in the facility and find out how you can meet them. You might be like, that's totally impossible. Well, let me show you some examples as we go through our time together of where this might actually work for you. So, keys to a more successful pitch. Be very clear about the regulatory requirements out there. We have a bunch. I'm going to talk quickly in a minute about some newer ones. Write a plan that addresses the costs and the revenues. And you might not be aware of this, or you might feel that you don't have access to this as stewards. That's what I hear back most often. In my current job, we consult with 38 community hospitals in 4 states. And every time we go in and say, well, let's write some more resources for your stewardship program, they're like, we don't have access to where the facility revenues are. Realize that hospital budgets are an area of strain for senior administration as well, and there are people at your facility who can help you with this. There are definitely areas, and I'll show you an example around particular DRGs. If you can find the right folks in the billing office to help you, there's a lot of opportunity to be harvested there. Nobody ever goes and talks to them, though. And I'll show you one very successful example we have of that in our DASON network. When you have job descriptions, they need to be structured. They need to not be vague. And I will share a somewhat harsh example that happened to me in Rochester. I was in front of the board of directors. I was up at the podium, much like this, and I had just given the annual stewardship report. And the physician champion for stewardship was also the physician champion for infection prevention. And at the end of my presentation, he said, well, what we really need is a medical director position dedicated to antimicrobial stewardship. And I remember the COO of the hospital saying, well, what would that person do? And he said, you know, help improve antibiotic use. And I just want to tell you this in front of the whole board. This is a very stressful place to stand. And she turned to him and said, is she going to tell doctors to use fewer antibiotics? And he's like, well, no. It's like, is he going to go out, or he or she going to go out and meet with providers and tell them ways they can improve it? Well, that's a little vague. We'll have to come up with ways that they can do this. And the COO responded, I am not hiring another director of this or that at this organization until I have a bulleted list of what they're going to do every day. And that really hit home to me. And that may seem like overkill, but the reality is, as we go and we ask for these positions, and sometimes you don't know specifically what they're going to do every day, and I understand that, but you're asking for a lot of money for this nebulous director position without very concrete actions. So I'm not saying that you can't start with concrete actions and change them and grow, or you can't write them somewhat vaguely to encompass a lot of potential activities. But if you don't have a very structured position there, you need to, because that makes it much harder to understand what they're buying when this is in front of the C-suite. I'll also say we have great support. You heard this morning about the core elements for stewardship, and now it's part of our NHSN reporting. There are reports going out to hospitals that show how many of those priority areas are there, and having co-led programs with physicians and pharmacists, as well as having stewardship job responsibilities in their job description, are very important things now. I have CEOs calling me saying, I just got this report and we're a 4. How do I get to be not a 4? Because 4 is not the highest score. And I'm like, you have to have job descriptions that say stewardship in them. I've been trying to do that for decades. I have them now at our hospitals because it's there. So you can use those things to leverage, even though it's not a regulatory requirement yet, they feel like it might be. And then this also supports getting that funding and job positions with actual responsibilities for stewardship for our physician colleagues. Super important, and some late-breaking news. There is a brand new publication from the IDSA and HIVMA on Monday of this week, May 27th, that came out, and it is discussing the role of nurse practitioners, physician's assistants, and pharmacists in infectious diseases care and the team-based care model. And there is a statement in there from the IDSA that says pharmacists should be co-leaders of stewardship programs. So we now have it from ID physician professional societies, and we have it from the CDC. It's this late-breaking news. It's only in a preprint. If you look for it, you have to go to CID, and then look for those articles ahead of print. It's not easy to Google. But we have that out there now, so that's a great source of justification for getting those job descriptions and getting those positions supported somewhat. I find what works best, and this is, I remember somebody told me the biggest compliment you ever got is when my business administrator in DASON told one of my colleagues, be careful, Libby's a terrible negotiator, but you have to watch her because she always ends up with what she wants somehow. I took that as like, yeah, right, I can negotiate fairly well when you don't realize what's happening. And I joke and say, I do this well because I have a father, and I find that offering the different levels of intensity is important and very helpful to success. So put in your pie in the sky dream, because I think that's important. So often when we sit in a room, and I've done it too, when you're writing a proposal to get more resources, you might say, oh, I know they're never going to give us 2 full-time physicians and 2 full-time pharmacists, so let's not even ask. Ask. Put that in there. That's the model. If you can support it, do it. But also say, now don't promise to do everything with fewer resources, but say, there's also sort of this middle level model where if I get 1 pharmacist and half of a physician, we could do these things, but not everything. That's very helpful because sometimes, especially in Rochester, I would get what I call the leftovers. So at the end of a budget period or a proposal period, I would never get my full proposal. That would often go to the large CT scanner that they wanted to put at one of our facilities. But if there was enough left over, I would get the pieces because nobody had a proposal with small pieces in it. And so when you do that with different levels of intensity, you can start to build. The other thing is I will tell you, write a proposal, tell them what you're going to do, and when you do it, go back for more. I went from having a team of 9 clinical pharmacists when I started, and there were 21 when I left. And I did it by saying, they weren't all in infectious diseases, but I went in and I said, I'm going to go in, I'm going to do this, and I'm going to deliver on it. And I was right back there when it was done and said, look what I did, now give me more. How about more? I'm back again. And that works. When you have that slow track record of success, you can incrementally build things that way. So starting with different levels of intensity and being okay when you get that small level is really great for your program. Always include the clinical importance, but do not overstate. We, one time, the COO, she was really fun to work with, but she said, we were in a meeting once, and she's like, I literally just left a pitch that said someone was going to cure a type of cancer in an 18-month period at my facility. And that was just unreasonable, right? So be realistic. You might be very optimistic with what you're going to do, but certainly don't oversell, and that happens a lot in these types of proposals. And then getting back to that point I made about proving and doing what you said you're going to do, going back and showing them what you did is really helping to establish your credibility. You want to be the one that when there is a resource available in the hospital, the COO hopes to see your face. That's what you want. It will get you into more opportunities. It will get you more resources and your ability to work across units and divisions in your hospital because everyone uses antibiotics, so that's the beauty. I felt like I could go anywhere and dip my finger into trying to support problems and issues there with stewardship. So don't feel you're very limited in where you're going to go and what you're going to do. All right, so I have to stop and talk about, we have a great new regulatory lever, right, to get some resources for stewardship, and it looks like you have done a very creative model here in Nebraska where the health department is able to support some of you in getting your AUR reporting in. I just want to remind everyone, there is another way to help justify this. So AUR reporting, it's not pay for performance, it is truly pay for reporting. It is part of the PIP, the CMS Promoting Interoperability Program. This is something that is completely outside the normal realm of a pharmacist or physician day. Full stop. You have to go meet new people at your hospital to successfully leverage resources for this program. But there is someone who typically has the title of PIP coordinator, at least in most of our hospitals, that's what they're called. They live in the quality realm, or maybe in information technology, or maybe a little bit in both, and they are very worried about this. In fact, at 4 of my community hospitals, those people were trying to contract with an outside organization to do AUR reporting. They had never heard of antimicrobial stewardship teams. They didn't even think of this as a pharmacy initiative, and I'm already doing all the reporting for them. That was a great day when I was like, okay, so if you had that budget, do you want to fund some more consultative stewardship services? But this is a group who is tasked with meeting these requirements. I just want to give some important caveats because I get a lot of questions about this. So one, to get the credit, you need to do all the things, and AUR reporting is just one of the things. So they're all listed up here, and we can share these with you if you like. So that is very important. So there are some hospitals who have already decided they are not going to meet because it's all or none and are not pursuing AUR reporting. So that might be the answer you get at your facility, and this might not be the great magical support for stewardship we hoped. The other thing is the money that comes from this, it's not an additional payment, it's a part of holdback funds. So CMS holds back a small percentage of your CMS reimbursement every year that pays you based on your ability to do things like this. Again, completely different than the core measures and all the public reporting measures that you're used to seeing and hearing about. The holdback, though, is significant. And when I don't have great data for Nebraska, so I'm sorry, I have data for New York. And I know that in New York, the penalty holdback for hospitals starts at $1 million and goes to about $27 million. So it's really hard to get this number, quite frankly. A lot of people keep it very close to the vest. It's not a publicly reported number that I've been able to find. But this is something to tap into. This is money not coming to your hospital if you don't do it. And I can't say how disappointed I am and how often I run into the situation where the quality team is not talking to the stewardship team to get this done. So if you haven't already met that PIP coordinator for your organization, I would say go on an expedition to find them. They're a great resource to help you. And this is just to remind everybody what's required for calendar year 2024, which we're already well into. Don't stress if you haven't already gotten there. It is not due until January 31st, 2025. I wouldn't wait till then to do it, I promise. I predict NHSN is going to struggle on that date with all the submissions. But you still have time. There are lots of ways to meet this requirement, but there's a lot of money on the line for your hospital. And I don't think anyone has really put it together with our stewardship team. So that's another great regulatory component that you can bring into your business proposal. All right, so let's talk about a few things. Trying to get a medical director. This is something I always encourage people to do. Get out of our stewardship silo and go talk to other people. So if you want to have a medical director position funded for your program, go see what industry experts are saying about that. These are consultants on how to write a position description and a job posting that hospital administrators use for medical directorships. So look at what that industry guidance is. I'll tell you, use my slides for this. I went to this website. It's very easy to get all their information for free, but they call me every day because they think I'm a COO of a hospital. And they're like, do you still need a medical director? I'm like, nope, sorry. I just looked at your site, just spying. So use my spy work and don't go put your email in here, ever. Because they took my phone number off my automatic reply. That I didn't, so think about that. Don't put your phone number in your automatic replies. But they say a lot of the things that we've talked about. So make sure there are specific duties that are measurable and actionable. Don't say this person's going to do everything. Say how they're going to be supported to do what they need to do. Avoid non-specific or open-ended duties because it leads to confusion. I like this one. Avoid having physicians turn in stacks of time logs. Don't track their time, give them support, and let them go do it. But lots of great advice here on what executives are being told to look for in a medical director position, because I think that's a common element of any stewardship increased resources ask these days. Okay. Now let's pivot a little bit and talk about the very fun topic of costs and revenue. I have a lot of business people in my family, and right now they all are having chest pain, and they don't know why, because I'm the pharmacist, not the business person. But don't worry, when you masquerade as an administrator, you learn some of their tricks. So I think we often think very concretely about how we have to calculate savings, and that we have to be able to very specifically turn in a different dollar amount. But the people reviewing your proposals are very used to forecasting and using estimates to describe what you can achieve, which is a lot more robust than just showing the difference in the pharmacy budget, which for years is how we were able to do stewardship. But we have finally gotten off the list as being the most expensive group of drugs in the hospital, but that's a little bit to our disadvantage. We can't just go in and be like, oh, okay, yeah, I'll just pick a cheaper this and give me 6 people. So we have to be smarter, but our infection prevention colleagues are ahead of us on this and actually have some decent estimates. So we can look at drug-sparing interventions, which is just the cost of the saved drug. That's hard to do. We have a lot of facilities who are getting towards optimal amounts of use, and so you're often switching from one drug to another, not eliminating a drug, so there's just the differential cost there. But if you're doing it in a way that will have another important outcome, like an avoided infection, you can actually include those estimates as well. These are somewhat dated. We still use them in our DICON, our infection control network. They're from 2013. We're actually working on trying to get updates of these. But there are established estimated costs based on 2012 dollars. There are really easy ways to inflate these using standardized calculations for all of the healthcare associated infections. So we need to think about this, right? There's lots of opportunities that we could put into proposals. And if we can get everyone at the table helping together, so you need micro there, you need pharmacy there, and you need infection prevention there. But if you have an intervention that might bring in a rapid diagnostic that can help us better identify certain infections or identify that patients don't have certain infections that would get them off this potential list, that's savings. If there's a way to use a preventative anti-infective or a preventative device, you can then calculate the offset from the infections that you prevented. And I'll show you some examples of this in a minute. And it's not that hard to do. It sounds a little intimidating. It's pretty easy. So let me start with my first case study. And this is just using benchmark targets on antibiotic use. So this is data. This is, can you all see that? Can I just dismiss? Okay, so this is somewhat simulated data, somewhat real-time data, and I'll tell you, if you had reached out to me to become a DASON hospital, you might see very similar figures to this in your initial proposal. So this particular health system, for ease of calculation, we're just going to say they have 1,000 patient days per month. That just makes it easy for our example. So you can see their use of fluoroquinolones, anti-pseudomonal beta-lactams, and ertapenem. And then I show what our benchmark is in DASON. So we get some initial cuts of data, honestly, usually from purchasing. We transform it to DDDs. We show the difference between DDDs and DOTs. I can talk to you about that offline if that is of any interest. But we're able to show in DASON hospitals that have been there over a year where we can get their rates of use with the typical interventions we deploy. And then we can look at our delta here and say, this is the rough difference that we can provide. And then we have a cost per day for each of these. Now, these are absolute reductions in overall use that we usually can do. Usually when we go into hospitals, there's a lot of low-hanging fruit that we can just get rid of. And so I can go in and say, just by getting you to our benchmarks, just to our average rates, I can save you around $16,000. Now, not that exciting on a month-to-month basis, but it adds up with time. But there's more that we can do as well. Now let's take our example of the fluoroquinolones and try to delve into that a little bit more deeply. So we also asked from our hospitals, how many C. diff cases did you have? And this sample hospital had 13 cases of hospital onset C. diff. Now we're talking, right? So now there's real reporting and money on the line, one. And I can go in and use the data from the CDC. It hasn't changed, it's from 2014, but I'll tell you, this was modeled data, but it rings pretty true. And it says that if we can reduce the use of high-risk antibiotics, largely later generation cephalosporins and fluoroquinolones, by 30%, we get a 26% reduction in C. diff. It's almost one-to-one, right? So if I go in and say, now look at this, what if we take you to reach just 113 DOTs at this hospital, not down to the DASON benchmark? I think I can do better. That's a 30% reduction, right? And so then I can get you down 3 cases of C. diff, and then you apply those calculations, and now you're down to over $33,000 in addition to the money you're going to save on the drugs. And so these aren't hard calculations. They're becoming more and more common, and I think we just don't think about it in this way. We've really been siloed, but I think we need to start coming together more and having the lab at the table in our DASON network. I didn't bring a firm example of this, but there's lots of times where we can show we have the drug overuse problem to justify a new diagnostic in the lab. That's really easy to implement, but the lab doesn't have the justification for it, and we couldn't change the drug use without the lab. And so going together as a team is a great strategy to garner more resources for your facilities. Now, There's also opportunities to talk about increased revenue, and I think, quite frankly, it is a surprise when the pharmacy comes in and is like, let me tell you how you're going to get more cases in the door, and so you get a lot of interest. But this is also something out there that you can absolutely do, again, if you found that person who understands which DRGs are your problem areas for your facility. They also sit in the C-suite, typically, usually under the CFO in some regard, but they're the ones that have all the data on health insurance reimbursement, and there is somebody at every hospital in America who can tell you what their #1 unreimbursed DRG is. It's the bane of their existence. And so you just need to find that person and get creative about what those DRGs are. So what you need to do this is you need to quickly figure out how many bed days will be freed up by an intervention. I'm going to walk you through an example in a second. What is the average length of stay for your facility, and what's your payer mix? Because 100% of payers aren't going to fall under the correct payer mix. And one of a confidently held misbelief in antibiotic stewardship and infectious diseases is that if you put your patient on an IV antibiotic and they have a skin and soft tissue infection, they automatically qualify for admission, and they don't. And so there's a lot of admissions, and I don't know, this is again something I learned as a pharmacy administrator. You know, there's a lot of admissions that come into the hospital and we treat them, and then we never hear what happens to the bill. What actually happens is the insurance company will be like, no, that didn't qualify, we're taking our payment back. And these are completely uncompensated admissions in the hospital, and there's really no great way to go after that. Usually a patient gets a bill and it gets written off. But there are interqual criteria for admission. So these are readily available on various websites. I've listed one here for you. And so these are actually the criteria for admission for SSTI, and it's just antibiotics. It's not IV antibiotics, but there are a lot of patients who come in who don't meet any of the clinical criteria here. They just have a cellulitis, and people are worried that they won't thrive in the outpatient setting. There's 10 other reasons. One of the most common reasons is they don't have great primary care follow-up to go rely upon. And so they get admitted, and again, in the ED or the hospitalist team usually admitting them decides, well, if I just give IV antibiotics, I can justify this admission. The same person who knows which DRG is the most uncompensated at your facility is also really happy to come talk to people, because they often don't get invited to meetings with clinicians, and they are very frustrated by these confidently held misbeliefs. So that's what we did at one of our hospitals. And this is, I won't tell you who they are, but this is their real data. They had about 300 admissions a year for cellulitis. The total number of patient days was over 1,300. Their average length of stay was 4.36 for these patients, but their benchmark was 3.74. So that's one problem there, right? That's something to talk about. The patients who came in for cellulitis stayed longer than the reimbursement really paid for. But shockingly, based on that no IV antibiotics justifying admission, 36% of their admissions did not qualify and had the payment rescinded. And the payment per case from their biggest payer was about $6,000. So if you take those 299, 36% failing admission criteria, no reimbursement, that's 107 avoidable admissions, and at $5,900 a case. Now we're in the big dollars, right? This is a lot of money the hospital had to give back. This hospital literally wrote a check to their primary payer for $635,000. That's money somebody really cares about. That's real money. That's not, oh, I might prevent a C. diff infection. This is money that's going back. And that doesn't even take into account the fact that if you have a really good cellulitis program, you might get your length of stay down. And every patient that goes out one day earlier, that's an additional patient in the bed, right? So that's an additional, and you make your most money when you put a patient in a bed, because you get the DRG, and then every day they're there after that, it's almost diminishing returns because of the way of our health payments go here in the US. And so it's really something to think about. And I think these folks who know which DRGs are there, I have a feeling if you could have the list of top 5 in your facility, they mostly involve antibiotic use. And there are great ways to justify. I know a lot of people are looking at some of the longer acting injectable agents right now and what might be really valuable there. This is money to harvest for those programs, but it's not money that pharmacists typically talk about. And this is where if you can get to those right people, you can start sharing those resources and discussions. Because it's really easy to support. At this facility, I will just quickly tell you what we did. We used this exact calculation to justify getting these patients, so they hired a dedicated care coordinator for the ED, and these patients did not get admitted. These patients were given a follow-up with, they had a sort of a rapid access primary care place, but these patients were never prioritized for it, the cellulitis patients. They were given a follow-up at this outside PCP if they didn't have one of their own. It was owned by the organization. And then they had this care coordinator nurse called the patients every day. Because a lot of cellulitis, as you know, it's not about it's not the magic of the antibiotics. It's, are you keeping your leg up? Are you doing the things you're supposed to do? Are you washing? You know, those things, and just being able to give that encouragement. And I'll tell you, when we went in, during the review with the C-suite on this program, one of the, I think the CNO said, well, are these patients able to get their antibiotics all the time? And we're like, well, that can be an issue, but these are fairly inexpensive antibiotics. And the CFO said, well, what do they cost? So we gave him a list of what it would cost for a course of Caflex and a few options. And you know what he said? Give them the antibiotics too. So this program now hands the patient their bottle of antibiotics in the ED, appropriately labeled for dispensing by the pharmacy, but went through all those issues, and now they've had great success. But it wasn't until we found this person who was so aggravated by all the returned payments that we were able to justify that. So go look for these. You know, just go ask. There's always people looking for help, and you want to be the group they want to call, right? So this can also apply in other settings. So for my long-term care people, this is a failure story from North Carolina, but hopefully after what I've seen today, I think you all can succeed. So there are nursing home fines that they're leveraged every year. They are extensive. You can actually go, there's a spreadsheet of them you can search online if you're interested. You can find out exactly why all the citations were there, but the money goes and sits in a pot that is general and used to generally improve care of nursing home patients. And so it doesn't have to be like, oh, they got cited for improper documentation of a narcotic, I have to have a narcotic initiative. It's not like that. Then this money sits with the states and various groups, and you can go do quality improvement projects for the nursing home. This is a rich pot for stewardship and infection prevention in nursing homes, and it's really easy to justify. This is our deal. North Carolina was third among states with unused funds, so we said, pot of money, I'll be there. So we went and we made a great proposal. They turned us down quickly. But don't let us discourage you. We get told no a lot in North Carolina, so we do not have all the great things you have. Consider it as a source to help garner your programs. You know, if you're trying to spread programs into outreach in the community and long-term care, these can be sources to tap to help these programs grow and to get that seed money you need to get started. So lots of unique opportunities to find funding out there if you just look. Now, there are additional resources for cost calculations from a few different groups. SHEA has some examples on their website, and a group, the AMMI group in Canada, includes an ROI calculator for stewardship initiatives, which I find really helpful. You just have to obviously do the Canadian dollar conversion. It's round numbers, so it's not that different, quite frankly. Now, let's spend a few minutes before we open up for discussion just on the proposal itself. So I've already said some of these things, but let's just go over them to remind you. If you sit down to write the proposal, so you've gone out and you found this problem in your facility that stewardship can help. And so, you know, highlight all the big things, regulatory needs. And now think broader, think nursing home requirements, think requirements in the community. You know, there are payment incentives for physicians doing stewardship training. Can you do something along that line in your primary care network? Can this proposed work be fit into an existing FTE, or will an easy change free up time for the initiatives? I have no scientific data on this, but I feel that my proposals were always more successful when they started with harvesting something existing and repurposing it and then asking for a little bit more on top. So if I go in and say, if I can decrease the number of patients on vancomycin, because I have this rapid test to de-escalate patients off of vancomycin, I free up this much pharmacist time a day if I can reduce their vancomycin needs because they're not doing PK. And in that time, I can have them do penicillin allergy assessments and work on S-Trianam use. But I can't do it without these three other resources. That's probably what you're doing anyways. You're probably already looking at a way to incorporate the work into your existing workflows. Put it in your proposal. That's very favorably viewed when it's clear that you aren't just being like, gimme, gimme, gimme. You're like, we can do this. We're just this short of getting all this greatness done within our existing resources. Very, very positively received in my experience. We have done this successfully in DASON, where we have found a little bit of time in the medication reconciliation technician workflow to be able to pivot towards penicillin allergy assessments. And then also moving things when we can into the EHR. So sometimes we need a consultant to build the EHR workflow that will free up hours of the day for a pharmacist to do other work. Think about that. Those are great strategies to get your resources. But if you just went in and said, I need $50,000 for a consultant, if they don't see really the back end of it, that's hard to justify. And then I think you've probably gotten my gist that using proposed work to meet another need in the facility is always successful in my opinion. So every organization has an annual report. It has their pillars or their strategic plan or their goals. The more you can use their language in your proposal, because the people reviewing these are spending all their time in that strategic plan document. You know, those are their words. Use their words in your document to show, you know, don't expect them to make the connection of like, oh, well, if we decrease fluoroquinolone use, we're going to have less C. diff and we're going to have less adverse drug reactions. You got to tell them that. They're not going to spend the time. They're busy. They're not going to make all those connections themselves. So put it right in there. And then also, of course, work with your goals around various HAIs, because there's lots of opportunity where stewardship can really help there. If you haven't already implemented these, doing prospective case reviews of all C. diff patients is incredibly telling, and combining that and involving the pharmacy group in that is a great way to garner resources as well. Your proposal needs to have a lot of things in it, but it also needs to be concise. I think, again, back at Rochester, the chairman of the board when I was there was the former CEO at General Motors. And he reported to their chairman of the board. And he told us the story all the time. He's like, when you have your proposal, so a lot of people, and stewardship pharmacists are my people, you're happiest, right, when it's 100 pages, right? You're like, oh, I have all this documentation, I have all this information, I'm gonna make this very robust proposal. Well, our board chairman told us once about when he made this great proposal about realigning workflows at General Motors, and he took it to the chairman of the board, and he said it was a 500-page document, and the chairman of the board took it and took off the first 2 pages, handed the rest back, and said, I hope this is all I need. So you better have an executive summary. Like, think about it, like a lot of people just read the abstract. The same thing happens in the C-suite, right? So everything you need to say, it better be quick. 1 to 2 pages. Obviously support it with lots of great documentation so they can drill down into it and tell that it's well thought out. But don't think that more is better in your proposal necessarily, because you need to be quick and convince them. Do your regulatory assessments and your market analysis when you have them. They always like benchmarking. Include the job descriptions. Don't make them come back and ask for those things for you. The financial analysis, and meet with somebody locally in the finance group that can review it ahead of time, so that they're always willing to meet with folks, I found, and they kind of like tip their hand. They'll be like, oh, well, this is the problem with this. And you're like, great, so now I'm not going to get rejected because you have a problem with my numbers. So we go back and correct them. Have metrics of success. That is the way that you can go back to people and say, we did it, this is what we're going to do next, give us more, and have timelines that are reasonable so they can know when to expect a turnaround. I can't tell you how many times I got a new position implemented. We would have, this happened to me once with a neurosurgical ICU pharmacist. We got it approved in March. We hired him, and he started on June 1st. And on July 1st, the COO remembered she'd funded this position for me and said, hey, can you show me how much he saved in anti-epileptics? And I was like, he's literally just out of orientation. So but having those timelines is helpful so that they also benchmark on when they think they should need or start seeing results. How much staff is needed is also the pain of the steward's existence. There's lots of groups who've worked on this. There was a Canadian working group that did assessments to try to decide what was really needed per 1,000 acute care beds. Shea did CMS draft conditions of participation had to do a workload assessment. So before it became a requirement in U.S. hospitals to have a stewardship program, they had to do a burden of work assessment, and this is what they came up with there. Somewhat different numbers, but they're also out there, and again, that's what CMS uses. And then here is from Shea, where there was a survey done of existing stewardship programs and their existing support and what they needed to get to the goals for their program. And you can see there, this is all divided by bed size. We don't have updated data since this was out in 2018. It was the 2016 survey, I believe. But late breaking news, at around 6:30 this morning, SIDP dropped a new RFP. It is the reincarnation of a CDC broad agency announcement, or BAA, where they are looking for people to do pharmacist stewardship needs assessments for workload. So if you're interested in studying that or informing that, go out and look for that. It's $90,000 over 2 years to help describe what pharmacist workforce is needed for stewardship, which is a great opportunity, and we're really excited to have those data available to us as well. But you can rely on these resources if you want a good baseline benchmark. And then there are a few sample business plans. People have been taking these down, but these are the one I could still find out there. There used to be a ton of these. There used to be one on AHRQ. There used to be just in a bunch of places. I couldn't find them anymore. But the American Academy of Pediatrics still has one that you can use as a guide. But what I would suggest you do is go find what has been successful at your institution. So if somebody just got something and you want something similar, ask if you can have their proposal and use that as your guide, because you know that works. And so much of this is being able to justify the things you want and need for your program to the people who run your facility. And I can't tell you how important it is to know what your CMO's specialty is. So I'm in 38 hospitals, and I gotta tell you, when I want more stewardship resources and I go to the hospital where it's an OB-GYN, I am all the time talking about infections of pregnant women and neonatal sepsis. That is not what I bring to my hospital with a cardiothoracic surgeon as a CMO. I have an entirely different set of examples. And just those little simple things, I mean, they might sound a little goofy, but honestly, those are the differences between successful and unsuccessful proposals. You wanna talk to your audience and make sure they're hearing you. So with that, I think we have a little time for questions, I hope, but I hope this has been informative and you've learned 1 or 2 tricks to help garner more resources at your facility, because it does sometimes seem like a big mystery black box, but it's not as hard as it seems sometimes. Thank you.
Some proposals don't get funded. What would you suggest if you put forward a proposal and they said no thank you? What would you recommend facilities do?
Yeah, I've been in that situation a lot. A few things. One is think really hard about, like, if they gave you a reason, really take that to heart. They don't always give you a reason, but I find that mostly with personnel proposals, they tell you, they're pretty honest with you. It's not like a grant process, where they tell you why something else was better. I sometimes go back and wait for another cycle to submit. That's the easiest thing to do. Where I tend to get more success is when I go find a different partner to bring into the proposal with me. This was something that was very standard at the University of Rochester. I've successfully brought it to other places, but they had this, whenever we had a cost reduction initiative, so that, our hospitals would always come out, and it happens in all of our DASON hospitals, we need to cut 10% of costs, or whatever the number is this year. And you have to come in and deliver those costs for your unit. We had a standing rule at the University of Rochester that if you partnered with another department, you both got full credit. Now, I am not dumb enough to realize, to think that they didn't escalate what we needed to cut as a result. So you might need to consider that. But that keeps a lot of great cost-saving proposals off the list, because the director of pharmacy and the director of lab are worried about who's going to get credit for it. Go in with a proposal that says, look, we'll split it, we'll do this, we'll do that. That is incredibly successful. Even at hospitals, like I said, in our DASON network, who didn't have this existing rule like we had at the University of Rochester. Because I can't tell you how often things that always seemed untouchable, like not necessarily a stewardship issue, but radiology contrast. Wow, that's always a hot button topic. But we could tie things together there and have savings between radiology and pharmacy, and we both got to count it, so that was great. There are other tremendous examples where this can be done, and when everyone is pushing towards it and everyone agrees, you know, it's amazing how much more open to certain interventions people are when you say to them, look, we'll share the savings. That really opens eyes. Because I'll also say, I'll just quickly share a story. In my administrator role, I often had to approve the very high cost agents. And there was a provider once who called me, and I won't get into the details of the case, but it was going to be a $100,000 treatment that was not justified by the current literature. And the person on the phone said, I hope you take a nice vacation with your bonus this year from that cost savings. And I was like, oh, this is where it gets into the difference between how academic divisions and hospital divisions are accounted for. And I said, I don't get a bonus. I said, the money, the $100,000 we're not spending on this drug is the $100,000 that's going to go to buy the new CT scanner, or towards the new CT scanner. And it's incredibly eye-opening. So sharing that perspective, don't assume everybody knows the differences between how clinical care is paid for and then what are considered the cost centers, like radiology, pharmacy, et cetera, at your hospitals. It pays to learn that at your facility, because it was amazing. He was so much more congenial after that and so easy to work with. When he was like, okay, I need this for this reason. And I'd be like, all right, well, let's talk through the issues, but understand where the money is coming from. Not that you're gonna understand all the nitty-gritty details, but I think it gets you a long way. So go find those partners and then make sure they understand your considerations, that you have to decrease what you buy. They might have very different metrics they need that you can be very helpful with. And don't be too discouraged. We get told no a lot. I don't want to make it sound like we always get told yes. Well, thank you for having me here. I've learned a ton already, and I can't wait to see the rest of the day. Thank you.
All right, it is time now for a quick break. So go ahead and take a break, and we'll see you back in here at 10 o'clock.